Good evening. Hi, I'm Alison. I'm one of the paediatric neurology consultants in Oxford. So I was given the title of presenting cerebral palsy. So I'm just going to start and then we'll go through different aspects of cerebral palsy, and we can also discuss any sort of thoughts you have about it. And then at the end we'll have some cases. Um, the cases are maybe a little bit, we'll go through them, but they might be a little bit too in depth, but we'll see how we get on. All right. Let me just make sure I can move the screen. Okay, so the aim of this talk is to give an overview about the definition and types of cerebral palsy, an idea about the underlying pathophysiology and the role of the multidisciplinary team, and then we'll talk a little bit about management options for cerebral palsy in terms of the spasticity and dystonia that children might have, and then we'll move on to our case presentations if we have time, because I know we haven't got loads of time, but we'll see how we get on. So what is cerebral palsy? So it's actually an umbrella term because it covers a group of conditions. So it's like a spectrum disorder. So you can have lots of underlying like disorders that will then lead to that overall term of cerebral palsy. But essentially it's a permanent non-progressive motor dysfunction. And usually um, that permanent episode of episode that's happened to the brain that's caused this non-progressive motor dysfunction happens usually around the time of birth, either antenatally, perinatally, or postnatally, but it can actually happen anytime, usually they say up to about the age of 4 years. And that's sort of just, I guess, the way they sort of describe cerebral palsy and in terms of what they might be able to then determine what the causes might be from it. And that it can affect tone, posture, and or movement. And it can affect 2 to 3 per 1,000 live births. And the risk increases with decreasing gestational age and birth weight. So if you have a baby who's born at say 26, 27 weeks gestation with a low birth weight of say 800 grams, then they're high risk for having cerebral palsy. And that risk will increase depending on whether they then go on to have meningitis, whether they have intraventricular hemorrhage. And so but essentially that's where the risk comes from. But there are other risks as well we're going to go through, and other underlying disorders that can cause cerebral palsy as well. So like I said, it's this umbrella term that we use, and it's when our complex motor system is impaired and that the fluidity of that control breaks down. So our movements are very fluid, and our arms and legs do what we tell them to do. But when there's something that's impaired or an impairment that's happened, such as a non-progressive motor, we then get this non-progressive motor disorder that happens. And therefore, anything that can cause a lesion of the central nervous system can cause a movement disorder. And then overall prevalence in Europe, America, Australasia is fairly stable, like I said, at 2 to 3 per 1,000 live births. And this susceptibility for premature infants also increases the risk. So, and that increases to 100 per 1,000 live births if you were born before 28 weeks gestation. So it just shows that that risk really does increase and ramp up if you're born premature. So, so an injury to the developing brain in the prenatal through neonatal and early infant period. So that's really the underlying cause that can then lead to the diagnosis of cerebral palsy. And these lesions, or they call neuropathological lesions, are non-progressive. But although we say it's non-progressive, because children are, I'm just trying to reduce the chat size because it's got really big. So although we say it's non-progressive, because children develop at different rates, a different range, sorry, because I can't see very well because of the chat, may develop a range of secondary conditions over time that will variably affect their functional ability. So they do essentially get worse. So they do have more impairment over time, even though that lesion is non-progressive in that it doesn't change. But because of the impairment there, then we might see that widening of the gap between a normal child and a child who's got cerebral palsy. Um, and so cerebral palsy describes a group of permanent disorders of movement and posture causing activity limitation, and that is caused by this non-progressive disturbance that occurs in the developing fetal immature brain. So, so essentially, you're thinking about the causes of cerebral palsy can therefore be many and varied, and that's because of anything, any lesion can lead to its presentation. So there, it might be genetic, so genetic conditions that can impair brain development. It can be maternal infections that affect an unborn baby, such as chorion amnionitis. Um, and then there can be stroke. So stroke can happen within the perinatal period, and that can then cause an impairment of blood supply to the developing brain. There can be bleeding within the brain parenchyma, either in utero or as a newborn, or it can actually happen like as a young child if there's other causes for bleeding, such as trauma, and AVM. So any bleeding within the brain can then lead to a permanent non-progressive motor impairment. And then infant infections can cause swelling in or around the brain. Um, so that's typically meningitis, and just neonates and infants are particularly susceptible because of their immature immune systems. And then any trauma, a head injury to an infant, so such as a accident, a fall, or physical trauma or non-accidental injury can also lead to cerebral palsy. And then a lack of oxygen. So we might describe that as hypoxic ischemic encephalopathy that might occur around the time of birth, and that can lead to cerebral palsy. They've mentioned here that it's less common than previously thought, and that's because of there's been lots more sort of research into cerebral palsy, and this finding is less likely to cause cerebral palsy than what was first anticipated. And I talked about lack of oxygen to the brain during labour or delivery, but actually that can happen at that hypoxic event could happen for another cause, such as a respiratory arrest, if the child has got a chest infection or any other infection that might lead to then HIE as well. So this is just going through the risk factors for development of cerebral palsy again. So again, the classification is antenatal, perinatal, and postnatal, and it just talks about those different risk factors and how they happen. So the majority are antenatally causes. So 70 to 80% of cerebral palsy is usually an antenatal cause because of any of those listed there, such as prematurity, low birth weight, intrauterine infections, twin or multiple gestation pregnancies, and then pregnancy complications. And then this just also describes how there's protective factors in obstetric care that have come about in the last sort of 10 to 15 years, such as giving magnesium sulfate, the use of antibiotics, and also corticosteroids given during pregnancy if there's a risk of preterm birth. So that's those protective factors as well. So just going through the pathophysiology, and then that will lead us to how we sort of type and describe cerebral palsy. So in a preterm or premature infant, they are at risk of cerebral palsy, and that's because of the rapid phase of central nervous system growth that occurs between being sort of, I guess, when they're growing in utero and then up until about 5-6 months of age. And that leads to this more susceptible period of being susceptible to having cerebral palsy. And so there can be malformation, infection, damage, and disruption of emerging blood supply. And we talk about this susceptibility being in this central watershed or periventricular zone of the motor cortex. And then you can see on this diagram here, there's the lateral ventricles, and around the lateral ventricles, there's what we call the periventricular area. And this is particularly susceptible, especially in premature infants, and that can lead to PVL or periventricular leukomalacia or PVL. And so that's one thing that we talk about with premature babies a lot. Um, so then just thinking about the affected areas of the brain. So, and that will then give us our different types of cerebral palsy. So in the motor cortex, which is at the top, which gives rise to spastic cerebral palsy, which is 80 to 90% of cases. And then you've got your dyskinetic cerebral palsy, which is usually much less common, but that can arise from damage to the basal ganglia. And then you've got the ataxic cerebral palsy, which again is quite less common, only about 5%, and that arises from cerebellar damage. And then you could have children who have mixed types, so they could have a mixture of spastic, dyskinetic, or ataxic cerebral palsy. And then this just also shows us how we describe cerebral palsy depending on the area of the brain that's involved. So we have, again, the spastic, dyskinetic, and ataxic cerebral palsies. So spastic can then be further broken down into hemiplegic, diplegic, and quadriplegic. So hemiplegia is one side of the body is affected. And so in this diagram here, you can see it's the left motor cortex that's affected with the red area on the brain. And so it's the right side that's caused the hemiplegia. And then you can also have diplegic cerebral palsy. And this is more that there's bilateral impairment. And the diplegic cerebral palsy is also when we get the PVL, so the periventricular leukomalacia, can lead to this diplegic cerebral palsy type where just the lower limbs seem to be affected. Um, and it's usually caused like a scissoring appearance of the lower limbs because they're so tight with increased tone and spasticity. And then you can have quadriplegic, so obviously that will be all four limbs affected. And then going into your dyskinetic cerebral palsy, which is caused by injury to the basal ganglia. So you can have athetoid. So this is the type of movement that you might have. So it's a continuous sort of movement disorder where the child is always moving. And then you've got dystonia where they have this more tightness. And again, that can be all four limbs or just one side of the body affected. And then you have ataxic, which is the cerebellar. So you're just your balance is and your coordination is affected predominantly as well. Okay. Um, so cerebral palsy is characterized by is quite heterogeneous. There's different risk factors which we've gone through, and there can be a different underlying specific etiology. And you have your clinical features, and then you've got your severity of functional limitation, which will grade a bit later. I'll show you different ways that they grade cerebral palsy. And then there can be associated and secondary conditions because of the cerebral palsy, which we're going to talk about. And then there's treatment options. And then there's evolution of the condition over the lifespan of the individual as well. So going back through our cerebral palsy types, so spastic cerebral palsy, we had the three different types, diplegic, quadriplegic, and hemiplegic. And this is just a diagram of the MRI where we can see that there's periventricular leukomalacia. So around the lateral ventricles, there's this area that's really susceptible and most susceptible in prematurity. And you can just see those areas highlighted. So if we have a child who's got diplegic cerebral palsy or they've got diplegia, so they've got tightness in the lower limbs, they're referred to clinic as sort of query cause for this lower limb tightness. We first line will do an MRI, and that's specifically looking for evidence of PVL. And that can also be present in a child who's not particularly premature, so say a 36, 37 weeker, and the history isn't that like clear for having cerebral palsy, but then when we find it on the scan, then we have our underlying cause. If the scan is normal, then we might then go to look at more genetic causes of having tightness in the lower limb. So hereditary spastic paraparesis is another reason, so that's more of a genetic cause. So we'll do genetic testing as well. So yeah, I just mentioned again about the different types of cerebral palsy here. So and then really just talking about that depending on the type that you find, so whether you have hemiplegic, spastic diplegia, or spastic quadriplegia, then that can also give you an underlying reason or like thought process about what might have caused it. So I talked about the periventricular leukomalacia with spastic diplegia. But then with hemiplegia, the child may have had perinatal stroke, a periventricular hemorrhage, because you're thinking about a lesion that's affected just one side. Um, and then you can have, say, a neonatal cortical infarction as well. So it's usually sort of some event that's affected just one side. And then quadriplegia is usually something that's more global, so a global event that's affected the brain because it's going to affect the child systemically, essentially. So this suggests severe perinatal asphyxia at term, such as hypoxic ischemic encephalopathy, a postnatal infection such as bacterial meningitis, or say TB meningitis, or that the child might have a metabolic or genetic disorder that's then leading to this. Another cause of, say, a spastic quadriplegia might be a child who's had connectura, so high bilirubin at birth. They sometimes also get a movement disorder because of the connectorus, and it affects the basal ganglia as well. So yeah, that's just another thing to think about. So we talked about the extrapyramidal cerebral palsy comprises the chorioathertotic, dystonic, or dyskinetic, and these are the movement disorders, particularly because the basal ganglia being affected. And like I said, that's connectura, so that's the high bilirubin. Can also be caused by HIE and the neurometabolic or neurogenetic disorders. Um, so early signs of cerebral palsy. So if we have a baby who is referred to us at, say, 6 months of age, what are we looking for? So the looking at how the baby handles, the tone. When we lift the baby up, is there head control, or the baby's head just like is floppy and falls back? How stiff the baby feels, and when we lift them, do they overextend? So is there sort of dystonic posturing when we hold them? Do the legs feel stiff? Do they cross or scissor when picked up? And then in a baby older than 6 months, we're thinking about like a delay. So they're not rolling, they're not bringing their hands together. They may only reach with one hand. So they might have hand preference. So usually a child will only develop hand preference at around 18 months to 2 years. So if we get hand preference around 6 months to 12 months, then we're thinking there might be some underlying cause for that, such as maybe a stroke in the perinatal period. Um, and then when a baby or child's over the 10 months of age, we're again looking at how they're crawling, how they're pushing up with their hands, how they're starting to learn to walk, can they pull to stand? And so all those parts of the developmental assessment are really important to look at the child and observe. So observation is really key at these time points. And then just in development, we're thinking at not sitting by 8 months, not walking by 18 months, and hand preference less than 1 year, or red flags in the history that might suggest that we've got a child who may have cerebral palsy but needs further investigation. And then factors associated with a higher risk of cerebral palsy. I think we've gone through most of these already, but brain malformations, genetics, HIE, in utero perinatal stroke. IVF is actually increased your risk of having a child with cerebral palsy, connectorus, low birth weight, maternal disorders of clotting, just because that there's more increased risk of having a clot around the perinatal period. And then maternal fetal infections, coronary amnionitis, multiple gestations, neonatal seizures, neonatal sepsis or meningitis. So when we're asking about the way the birth history, and in a child who's presented to us at 6 months, who's say not doing what they should be doing, not there's developmental delay, we're thinking about all these underlying causes that might then lead us to a diagnosis. We sort of talked about all those risk factors already. Other risk factors might be preeclampsia, so high blood pressure around the time of birth in the maternal, in the mother, placental abruption and APGARs less than 7, so the baby therefore being born in poor condition. We talked about prevention. So I think the only thing we didn't talk about here in prevention was HIE, if a baby has HIE at birth, and they will then usually be like they have therapeutic hypothermia, they're cooled for about 72 hours in the neonatal unit. So they're cooled down to 33 degrees for that whole period of time. Um, Delayed cord clamping apparently, yeah, is preventative, and that's because there's just more blood around in the baby at that time. And then antenatal care and postnatal care are also important for prevention of cerebral palsy. So this is just to describe another way that once we've got a child who's been diagnosed with cerebral palsy, usually our community paediatricians will then be able to describe their functional ability using the GMFCS classification system, and that stands for gross motor function classification system, essentially. So, and that's graded from level 1 to being the best to level 5 being the poorest, to a child who's got, say, quadriplegic cerebral palsy and is unable to have any head control. They need head support. They need assistance with a manual wheelchair to be able to get to where they need to go. So level 1 is just that they can do all activities and they may just have a very mild impairment that means that they're not quite as balanced as they should be compared with a normal peer-related child. And then anything in between is graded 2, 3, and 4. And it's just a way of being able to sort of, when you describe a child on your letters, communicate with other colleagues, and then someone has a really clear idea about how significantly they're affected by their cerebral palsy and what's extra additional support that they need. And then this leads us on to associated conditions with cerebral palsy. So that can be that the child might have intellectual disability, they might have a developmental disorder such as ASD or ADHD, they are more likely to have epilepsy, they might have visual impairment, hearing problems, feeding difficulties, meaning that they might need a gastrostomy or a NG tube. But that might mean that they also may just need to have a speech and language swallow assessment to be able to determine whether their swallow is safe to start with. Their growth failure, so how are they growing? Do they need extra nutrition? And then they may also be more susceptible to constipation or reflux. And then because of that swallowing difficulties and swallow impairment, they're just more at risk of chest infections, aspiration, and then just chest infections per se is if they're not breathing the same as they should because they're hyperventilating or they've got scoliosis. And then children may also have really significant drooling and secretions because of their swallow impairment. And so sometimes the children might have Botox injections into the salivary glands to reduce the amount of secretions that they make, just because it can be really sort of on their quality of life, can be really difficult to control because they're just constantly drooling, their clothes are soaking wet, and they're constantly having to be changed. And that's really difficult for other carers. They can have really significant sleep disorders, and that means for the family that no one else is getting any sleep. If the child's not sleeping, then the family is just really struggling. And then pain can be due to the spasticity or can be due to the reflux, can be due to many different causes. They can have hip dysplasia, they can have hip dislocation, and that can all lead to pain. And then orthopedic problems such as scoliosis because they don't sit well, and therefore they may then need to have scoliosis surgery later as well. So there you can see that having cerebral palsy, that umbrella term, despite whatever the underlying causes, can lead to lots of different associated conditions, and that's what we're kind of monitoring for. So as a community paediatrician or paediatric neurologist who might look after these children, then it's sort of this multidisciplinary assessment of their neurodisability, and that's like constant, and working with all those different members who might highlight these different areas that the children have concerns with. So the treatment goals for children with cerebral palsy, so you need an MDT approach and that's really vast number of people in your MDT, and that's because you want to maximize their functional ability, and their functional ability also includes not just the ability to sort of sit, or how they might, but also how they might interact with the world, so how they communicate, how like they might need software that allows um, just eye coordination to be able to like use computer systems to be able to then communicate what they want. It may be that they're able to get to school, or how they're going to get to school, how they're going to function at school, are they in the right setting? And so there's just so many parts for that, maximizing functional ability, but also quality of life as well. So these are all our different members of the team who care for children with cerebral palsy. Um, and there's many more as well. This is just a sort of snapshot. Um, I think I've probably missed off school teacher, which is really fundamental, but essentially you've got a whole range of people who are looking after children with cerebral palsy, and often we meet together to discuss how we can manage a child and keep them in school, um, keep them being able to attend like hydrotherapy sessions, and be able to improve their quality of life. So recently I had an MDT about a child who is 4 years old with cerebral palsy, secondary to HIE, and that was because they were had really significant swallowing problems, and they were just it was affecting their ability to breathe. And then the school were always calling 999 because they weren't sure whether the child was sort of aspirating or choking. And then there was sort of a lot of discussion about what point should they be calling 999, how can, because then the parents get called from work, and then it's lots of discussion about how that we might be able to support school better. um, so we were able to work all together to be able to put in a plan that then allowed him to stay in school. So this is just a little bit about management of increased tone spasticity, which is a problem because of the motor disorder that happens because of cerebral palsy. So and there's different ways you can do that. And the reason you manage the tone is because it can be quite painful, and also can lead to quite a lot of contractures and difficulties like being able to be hoisted and lifted. Um, so you can have generalized sort of oral medications that are systemic. So that's oral baclofen. You can have localized injections with Botox. So that would just affect just the, so if it was just an isolated right upper limb that was particularly affected, then you could have Botox into, let's say, the elbow, so that then the muscle groups would then allow the arm to relax, so that then the arm wouldn't feel so tight and painful in when it's contracted. Um, so the, Botox only lasts for 3 or 4 months, and then would need to have repeat injections. So that's one negative side of it, because it's like another attendance to hospital. Whereas oral baclofen is more systemically initiated, so it would therefore might cause problems like with head control, or if the trunk was quite weak anyway, might lead to further weakness of the trunk. Um, and then you have another way you can manage spastic diplegia is selective dorsal rhizotomy, which where they do an operation on the spinal cord, and then that can improve the spastic diplegia. And then in severe cases, you can also use intrathecal baclofen, where there's a pump that's inserted and then delivers intrathecal baclofen to the child. Okay, so I talked a bit about these anti-spasticity agents, and then the invasive options was the Botox, so just skip that one as well, and then the intrathecal baclofen pump. So in summary, so the descriptive term of cerebral palsy encompasses the largest group of childhood movement disorders, and you have a multidisciplinary team approach is vital for all aspects of care to improve function and minimize disability. And from a medical viewpoint, the focus should be on sort of developmental and clinical comorbidities, So that's going to improve the quality of life by focusing on these areas and improving them. So the child will be able to gain most from their environment and school. And then secondary, you might like focus on specifics of muscle tone, motor control, and posture. And so that might mean both medical management with drugs, but also supportive management with the right seating, the right wheelchair, um, to make them as comfortable as possible. Um, and yeah, we talked about the different medical treatments as well. So I'm just going to go through some cases. Any questions at the moment about cerebral palsy?
Yeah, can I ask, Doctor?
Yeah,
Can I ask?
yeah,
Thank you.
yeah.
Regarding the community pediatrician,
Hmm.
what's the importance of it of such pediatrician to be in the multidisciplinary team?
Okay,
What
yeah.
is
So
his role and what's its is important?
yeah, so we have the community paediatricians. So their role is really to assess. They do developmental assessments, and as part of that developmental assessment, they would then be able to support the child with um, like accessing the right sort of community, so physiotherapy, occupational therapy, wheelchair services, and speech and language therapy, because a lot of those therapists all sit in the community teams, and so they work probably more outside of the hospital environment. And that assessment is sort of ongoing, and that will then those assessment processes then feed into what we have is an educational healthcare plan. So these plans therefore then allow the right, I guess, ability to say this child, if they go to this child needs a specialist provision, so they need to go to a special school because they have intellectual impairment, and they need further support because of that. And they also that there is funding. So as part of the educational healthcare plan, we often use this term EHCP. So that would then allow children to then have the right support financially to be able to access special schools. Um, and that means they might have a one-to-one, so that and the one-to-one is means that they have a teaching assistant who will then be at school with them, so that they would then help with all their personal care. For example, like if they have a gastrostomy, they will then access the gastrostomy at lunchtime to give them their feed or give them like their milk. Um, and so they'd also would be important for like personal care, so like toileting, if they're hoisted. So that funding is for that teaching assistant or care assistant to then be able to allow them to access school. So that's part of the community paediatrician's role really, to ensure that that's all in place for the child. Um, so whereas, say, a pediatric neurologist would be more involved with, say, the initial diagnosis of a child with cerebral palsy, and maybe if they had really difficult to control epilepsy, or a difficult movement disorder, then pediatric neurologist would be involved from that aspect, I guess.
Yes, yes, yes.
Yeah,
Thank you. Amazing.
sorry.
And
Yeah,
and regarding the gross motor function
yeah,
classification system, and on the other hand, the non-progressive, what we mean by non-progressive lesions in the brain or the
yeah,
CNS. So if the child has been designed as level 5 of this classification or level 2, let's say.
yeah,
So this means it's non-progressive. It means that it will not progress to
yeah.
level 3
Yeah, it doesn't.
at
It
some
doesn't
point of
usually.
his
It
life.
doesn't progress. No. Yeah,
Yeah,
you're
yeah.
right. That's yeah. It's
That's
static. That would put what would carry through the whole way. Yeah.
amazing. Thank you so much, Doctor.
Yeah. Okay. All right. So these are just some cases from children I'd seen maybe about a year ago. I think I've got like 4 or 5 cases. We might just do say four of them. The last one was a bit complicated, but let's see. Um, so This was a 4-year-old girl admitted following a prolonged generalized tonic-clonic seizure that lasted for 35 to 60 minutes. She was not known to have afebrile seizures in the past, and she required two PR diazepam followed by an IV lorazepam to terminate the seizure. And then it was interesting to note that when she presented to A&E, she then had this background history, including delayed motor skills, evolving spasticity with diagnosis of cerebral palsy in June 2020. And then she had a left convergent squint. She was premature 29, born at 29 weeks gestation, and she was one of twins. And then she also had bilateral cystic periventricular leukomalacia PVL on neonatal head ultrasound, and she had learning difficulties, and she was being monitored for right hip dysplasia. So I don't know if anyone wanted to sort of comment on this. Just I guess at this point we were thinking, obviously she's got cerebral palsy, and then she's had this first new onset seizure. Does anyone want to think about whether we would classify this seizure as epilepsy, or whether we might start treatment? I don't know if you wanted to think about that. Okay, so yeah, so essentially, so a child who's got cerebral palsy and they've got diagnosis of periventricular leukomalacia on the neonatal head ultrasound means that she was at increased risk of seizures and epilepsy. And therefore, in a child who's had one unprovoked seizure, which is what she's had, um, which is quite actually quite a prolonged seizure, you can then give the diagnosis of epilepsy. So normally a diagnosis of epilepsy, you need two unprovoked seizures that have happened. So they're not symptomatic for anything, they're unprovoked and they've happened. So but she's just had one. So, but because she's got a diagnosis of cerebral palsy, then we're able to give as per the International League Against Epilepsy, we're able to give the diagnosis of epilepsy. So interestingly, her parents were very much of the case they wanted to watch and wait. They didn't want to start any anti-seizure medication. They were a bit nervous, a bit worried. They didn't want to start it, so we held off. But then subsequently she had a further seizure, I think probably about 6 months later, and then we did start levetiracetam for her. I'll just because I can't remember the cases. So oh yeah, so in the end she came into hospital because of this prolonged seizure, and we then requested an EEG, MRI brain, because she'd only had the neonatal ultrasound scan when she was a baby. And then we started her on buccal midazolam, basically as a PRN. So if she was to have another prolonged seizure, and then we considered an anti-seizure medication, but would usually wait for the second afebrile seizure. But actually, because of, as I said, she's an unprovoked seizure in a child with cerebral palsy, you could actually start anti-seizure medication for her, but parents decided that they didn't want to. So this was her MRI brain scan. So this scan actually shows she's got quite dilated ventricles, and that's probably most likely because of atrophy of the brain parenchyma itself, rather than as say hydrocephalus. So this is more because of there's less brain volume. And then you've also got thinning of the corpus callosum. So the corpus callosum, I don't know if you can see my mouse, is this part of the brain here that connects the two hemispheres together. So the right side and the left side. And this is actually quite thin compared to normal. And that just shows us that she's had some white matter injury, and that's affected all those parts of the brain. And this just the shape of the ventricles. Normally they're much smoother, but they're quite dysplastic and not what you'd normally expect. The EEG was abnormal. It showed multifocal cortical pathology in keeping with her past medical history and a higher predisposition for seizure activity. This was just, again, just trying to pull all that together, saying, look at all these different teams who were involved in her management. And this was at the time she presented when she was 4 years old. So she has community pediatrics, physiotherapy, occupational therapy, speech and language. She has an educational healthcare plan. Um, she has a consultant ophthalmologist because she has a squint. She has an orthopedic surgeon because of this concern with the hips. And then she also undergoing private physio. She has early years specialist teachers and physical disability team and orthotics. And the orthotics are for splint, so because of the spasticity in her legs, the children often get fitted for different orthoses. And then at the bottom we've got she was then referred to paediatric neurology with Dr. Jaywant and was awaiting an appointment back in 2023 because of the seizure. Um, and then this is just in the middle, it says in receipt of DLA, which is disability living allowance. And in the UK, you get different levels of disability living allowance depending on your severity of your underlying condition. So she was at a high rate because her condition meant that she needed a lot of support. So that was community management. So then going to case two, so this was an 18-year-old boy who's just bordering on adulthood. Um, and I actually saw him in the hospice for a supportive care stay. So we've got the children's hospices, and the hospices are not just for palliative care, so end of life care, they're also for supportive care stay. So we often parallel plan. So a child who's might be not end of life, but just needing support and symptom management because they've got a very severe complex neurodisability, they will be managed by the hospice, and they come in for a period of time to allow their carers to have, I guess, some respite, because we'll have nurses who are doing all their management, so all their cares, medications, and it allows the carers then to go and have, say, a couple of nights off. So he'd come into the hospice in Oxford, and he had a background history of dyskinetic cerebral palsy, which was secondary to connectorus, which is because of high bilirubin. I think he was actually from Pakistan and was born in Pakistan, and his connectorus had happened there. And his dyskinetic cerebral palsy meant that he was very, like a really severe movement disorder. He had severe dystonia that actually had led to him going into ITU for status dystonicus, probably when he was about 16 years, no, younger than that, maybe more like 12 or 13 years old. And then because of that, he then had an intrathecal baptism pump, and he had medications for tone management as well. And that was what actually helped him get out of ITU and be able to get out of his status dystonicus. It was more of a palliative actually decision that there was nothing else to try, and that it worked for him and managed to get him home and actually carried on having quite a good quality of life. And then he was also non-verbal. He communicated through eye gaze, blinking, and he had a communication book with different pictures that he would then look at, and you would be able to then work out exactly what he wanted. He had a gastrostomy, and which was a PEG-J, so jejunostomy. And then he had a sleep disturbance, asthma. He was GMFCS level 5, and yeah, that was him. And this was the reason I put this case in, was because it just wanted to show the intensity of the management for his medications, because he was on clonidine, I think, 6 times a day. So it was intense in the amount of times that they'd have to give him this medication. So for his carers, it was a lot of work. So you can see at 3 a.m. he has clonidine. These are really big doses as well of clonidine, 900 micrograms. 7:30, another 900, 11, 3. So he's having a lot of medications all at different times, just to illustrate how intense his support was. So then thinking about a child who's 18, they're going to be transitioned to adult services. So they're no longer going to be under paediatrics. And that means quite a lot of change for the family. And this was just thinking about transition to adult services, how an MDT might be organised, how can we prepare families for transition, and the complex cases that we have, and also about advanced care plans. for families of children who have complex neurodisability. And those care plans are about what they would like to happen if the child was to deteriorate, and would they be for full resuscitation? Would we have a sort of revised DNA, like do not resuscitate, plan for them? So some families might opt for just sort of respiratory support, so just ventilation if they were to become apneic, but no chest compressions. So that's really um, for 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 this child. Um, Case three. So this was another interesting case. So this is a 4-year-old child that I saw again in the hospice for a supportive care stay. So with a background of hydrocephalus, ventriculomegaly, who'd actually been found at 6 months old on a scan that was performed because the child had been macrocephalic and had been irritable since birth. So, and then they'd found quite a significant ventriculomegaly on that. So I'll just show you the picture. So this was his scan. So this was an MRI scan. So you can see the ventricles are really dilated. It's the right one more than the left. So it's quite significant. So because of that ventriculomegaly, he had something called an endoscopic third ventriculostomy by the neurosurgeons. And that's where essentially they then go in and they make because there's like, they think there's a blockage. So they then make this ventriculostomy that then connects the third ventricle down. I think it's up with the lateral ventricles to allow drainage. And if that doesn't work, then they then put in a VP shunt in, which then you can see that the ventriculostomy wasn't successful in 2020. So then they, within a month, they had to then put the VP shunt in to allow drainage of the CSF. And then had some more problems post procedure, had a CSF leak, had to have an EVD, which is an extraventricular device where you're on the ward having this CSF continuously draining. And then because of all these problems that had originated, we think probably congenitally from birth, he was diagnosed with cerebral palsy and had developmental delay. He also had epilepsy and had some other sort of GI issues which were completely separate, such as a laparotomy for intussusception and subsequent issues with that. And then he had issues with seizures as well. So I put this case in just to show the really significant ventriculomegaly and the CSF. And then you can see this CT was in January 2021 prior to his VP shunt going. So it had got worse from when he was in November 2018 when he was first diagnosed. So current medication, so he's on 3 anti-seizure medications, lamotrigine, Keppra and clobazam, and then he was also on medications for constipation as well, and rescue seizure medication, which was diazepam. So this was just examining him. So he was sitting in the supportive wheelchair. He needed head and truncal support. He was able to watch what his mum was doing on her phone, and he was dribbling, and he had a squint. And you could feel this shunt when you palpated the right side of his head and his neck. And he had a PEG site that showed some erythema present as well. We call overgranulation of the PEG. So again, this is just showed that high level of support that surrounds children with cerebral palsy. So you've got all your different teams: community, paediatrician, paediatric neurosurgeon, general surgeons, physio, dietitian, speech and language, occupational therapists, neurologists, and then orthopedic. So it's just really vast number of people involved. So yeah, again, just talking the same. And then I think I'll just do this as the last case because we're already at almost 7 o'clock. So this was a child who's 11 months old and was transferred in to the John Radcliffe for ongoing seizures which were refractory to medications. So she was transferred from her local hospital to the John Radcliffe, and that's for tertiary neurology opinion. So she had a background history of a severe neurodisability after neonatal grade 3 HIE. So she was born at term in her local maternity unit, but there was shoulder dystocia. So at 40 plus 2 weeks, As she was being born, her shoulders were unable to be delivered, and then she was born subsequently after a period of probably 10 to 20 minutes of delay and was born with no heartbeat, no respiratory effort, and required significant resuscitation. Um, and I think her downtime was about 20 minutes before they got her heartbeat back. And then because of that severe HIE that was suspected, she underwent therapeutic cooling for 3 days. As I said, down to 33 degrees, she was cooled in NICU. And then subsequently, she had an MRI that showed acute profound hypoxic ischemic encephalopathy. And because of that, she then went on to develop cerebral palsy, epilepsy, swallowing problems, needed a peg, and reflux as well. And those seizures were then that she developed were just had become like refractory to medication. So she was given lots of different medications. When she came to us, she was on 4 anti-seizure medications, so Keppra, Valproate, Phenobarb, Clobazam, and then we started on the ketogenic diet, which is another therapeutic treatment for seizures. And sometimes we do this rapid ketogenic diet start to try and get on top of things. And then because we were giving her so much medication, she was quite drowsy and quite sedated. So we were really worried about her airway, needing further respiratory support as well because of all that medication we were giving her and her reduced GCS. So I think I won't go through the last case because that was the last one is quite complicated. So I'll just summarize really. So cerebral palsy has diverse number of causes, including prematurity, intraventricular hemorrhage, meningitis, including TB, hypoxic ischemic encephalopathy, connectorous traumatic brain injury. You can have lots of different associated neurological conditions. So you can get dystonia, seizures, spasticity, hydrocephalus. There was many that I talked about, but these are the neurological conditions. And I missed out. Yeah, I did say seizures, epilepsy. And then you have your MDT approach, and that's because you can see this list is longer than all the other lists in terms of your MDT approach, because you just need to optimize their care from all these different aspects as well. So yeah, so that's the end of my talk. So any questions? It was a bit of a rapid. Cerebral palsy is really like such a big